We're some years away for the genomics to be applied to therapy and to make a difference in the way patients get treated. But it is a process that is happening, and in fact in some tumor types already is happening in the research institutions. It's not something that is happening at the community cancer hospitals, but it will get there.
Can you tell me, in terms of day-to-day medical practice, what has happened so far?
Well, one of the big things that has happened is that we are identifying subtypes of the tumors based on the molecular characteristics and not on the organ where they come from or what they look like under the microscope. And that has made a change. One example will be low-grade gliomas. They were always supposed to be tumors that you had time to intervene because it takes longer for the tumor to kill. But we always knew that some people with low-grade gliomas did react very badly to the cancer, and now we know why. These tumors look exactly like GBMs, the glioblastoma multiformes, which kill most people with brain cancer. So being able to identify these cancers very early on makes a lot of difference for the patients in the way they get treated.
And that means you can individualize therapy, does it?
Absolutely. We can. We have classifier sets that we can divide. We can define from the 33 tumor types that we have analyzed. We can define subtypes. We know what the molecular markers are and what makes them tick. And so we now can very specifically target to those molecular changes and make a difference in the way the patients get treated.
In the common tumours, though, are there any genomic features which are floating to the top that could give you an edge and actually help millions of people?
Absolutely. For some tumor types like lung, we need to delve deeper because they are very complex. They have high levels of mutation, so we have just scratched the surface. But some other types like breast, we have enough information to make a difference. We have one subtype of breast cancer that really looks very similar to ovarian cancers. And these ovarian cancers will look very similar to these particular subtypes of breast cancer. And as you know, ovary and breast are epithelial, but they are very different. And what this is telling us is that the changes have been so dramatic that these tumors are behaving as a total different entity from the cell of origin. And that makes a difference also because you have to go more aggressively to those.
We live in an era of targeted cancer medicine, and yet that target is moving. Can you throw any light on that whole process with the genome knowledge that's coming out now?
The problem we have with targeted therapies is that eventually the patient will become resistant to the therapy. And the reason the patient becomes resistant to the therapy is that with targeted therapies you have one single Achilles heel that you are going after. And if all the cells in the cancers don't have that Achilles heel, you are going to end up selecting for a clone that will start growing again and it's resistant to the therapy. And that is what we're saying. So what will happen, and it needs to happen, is an investigation on how we can put together a multiphasic approach to therapy. Basically, we still need to use targeted agents, but we need to use them in combinations. That makes sense according to what the molecular profile of the patient is. In fact, I see in the future that we are not going to classify the tumors as breast tumor luminal or oligodendrocytoma stage 2. We are going to say, well, you have a tumor that has mutations A, B, C, D, and E, and so since you have these mutations, we need to give you therapeutic agent A, B, C, D, and E, and maybe toss some F in there to make sure that it gets better. So we're not there, but we're approaching at a really, really fast pace.
Okay, so finally, what do you advise cancer doctors to be doing about this whole business right now?
Well, I think the best advice that I can give any cancer doctor is that, and any patient too, is that these combinations of mutations are very complicated. Really, no one that has gone, through medical school that is alive today has had a education on this. But we do have a group of professionals that know how to deal with this, and those are the genetic counselors. So my advice will be, if you get these patients and if you get this analysis and these diagnostics done on these patients, get together with a genetic counselor. They are going to be very informative, and they are going to help you a lot in figuring out what you can do for the betterment of the treatment of your patient.